My name is April Wilson. I lead the Insurance Discover business here at FinThrive, and today I'm excited to talk to you about how to use Insurance Discover to fight bad debt. It's a big problem for all of us, and we're excited to share a little bit about the problem, the research, and how to solve for it. So let's get into it. In today's session, we're going to talk about how insurance discovery leads to a reduction in bad debt overall. We're also going to talk about how it works with standard patient intake and screening processes. We'll talk about how to use automation to increase time to cash and reduce staff dependencies on more manual methods in order to search for insurance for patients that maybe didn't present with insurance at time of service. And we're also going to discuss how insurance discovery can actually reduce patient complaints and lower AR days. First, let's talk about the landscape a little bit. We'll start with the uninsured population. So as you can see from this chart, while we have the lowest uninsured rate in history, you can see a little bit of the legacy data here in this particular chart from 1965 to current. You can see with the introduction of the Affordable Care Act in the mid-2010s that we saw a significant decrease in the number of folks who were uninsured. However, it's been back on the rise ever since then, and it continues to be on the rise today. I realize this chart is slightly out of date, but it was the most recent information that I could find on this particular topic. So the uninsured population is significant, and it typically is a big driver of bad debt for our provider customers. The problem goes a little bit deeper than whether or not they have insurance coverage, because it's not just about being uninsured. It can also be that they have insurance, but in essence, they're underinsured, meaning that the total out-of-pocket cost would typically fall into a range that exceeds what their household expenses tends to allow. So you see on the slide here 3 different definitions of how being underinsured is calculated, and underinsurance is just as extreme a problem as the uninsured population. And it's typically down to a question of access and affordability. So on this particular chart, you can see that while employer-provider coverage has been traditionally on the rise over time, as well as individual coverage for marketplace plans with the introduction of the Affordable Care Act, they're typically more high-deductible health plans, which means it's more out-of-pocket for the patients. And typically, this is a pretty unpleasant surprise universally for all patients, and it leads to non-payment or underpayment for the services that were performed. More than 1 in 4 adults who were insured all year were technically underinsured. And this, again, is a little bit of an outdated slide, but it's the most recent information that I could find on this particular topic. It continues to rise as costs for healthcare increase, both with the providers and with the patient responsibility. So how do hospitals deal with this particular situation? Again, another chart showing the impact of high deductible health plans. It continues to grow year over year, and we are seeing some of the highest out-of-pocket maximums for patients today in 2023 than we've ever seen historically. So it does add up, and it does lead to being a significant contributing factor when it comes to bad debt. In the past, payers comprise the majority of the revenue that hospitals and other providers would receive. On average, their revenue from insurance companies or government reimbursement was around 90%, but that's changed significantly over the past 10 years or so. What we're currently seeing is that there are a significant amount of patient revenues that can be as much as 30 to 40% of overall hospital revenue. So really engaging with the patients and making sure that they understand their financial responsibility, as well as all of the different ways that they can pay their bill, including financial assistance screening. If you're a not-for-profit provider, there may be programs that you have internally that maybe you don't necessarily socialize as much as you could with your patient population that might reduce the burden of what they might owe you. And medical bills are a huge problem for families in the United States right now. About 1 in 4 currently have an unpaid healthcare bill. About 1 in 5 are slowly paying down a medical bill over time. In general, any patient bill that is $300 or more probably requires a payment plan. If you serve a community that is more indigent or more affected by poverty than other communities, that total patient responsibility could be $150 or less. So we're not talking about those $4,000 hospital bills that I think most people would struggle to pay. We're talking about what most providers consider to be a reasonable amount to ask a patient for, but most patients just don't have it available. So they will look for payment plans, or they'll look for credit-based solutions to see what they can do to honor their financial obligation. And then about 1 in 10 have a bill that they can't even pay at all. And they feel helpless, and they're not sure how to reach out and ask for help. So that's why it's important to have products like Insurance Discover in-house to help find the folks that presented as truly uninsured and see if you can find insurance coverage for them to lower that patient responsibility. But it's also important to communicate with the patients all of the different payment options that you offer as a provider, and make sure that you work with them to improve the patient experience. And in general, I think compounding the problem is the fact that most consumers aren't necessarily engaged in the cost of healthcare, right? In the overall landscape that we're in right now, it's typically a sort of a three-way tie between the providers, the payers, and the government in terms of how do we solve the revenue equation in healthcare in the United States. And really the two people that are on the outside of it, hospitals, doctors, they're impacted because they're not getting paid. It's harder to keep margins high enough to retain quality staff, but consumers really aren't part of the mix. And there's a big gap there. And it isn't that consumers don't care about it. It's just, I would say for the majority of providers, they've never actually been invited to participate in the conversation. And this goes above and beyond community initiatives where you might have outreach, you might have a dedicated voice group in your hospital or health system where you're getting that voice of the patient feedback. This is more around the financial side of it. So typically in those situations where you're facilitating patient meetings to drive more community involvement in the communities that you serve, the financial part of it isn't typically discussed. It's more clinical care, it's more adherence of medication, it's access to health care, access to treatment, and not necessarily how it gets paid for on the other side. So we strongly encourage you to have more financial involvement from your communities in terms of those sorts of conversations. Bring finances onto the discussion board so that you can get input and perhaps refine your financial assistance policies as a result. Cost sharing levels under many health plans now exceed the resources that most families have. Only 48% of Americans would be able to cover an unexpected expense of $400 or more. And there's actually been some more recent research in 2023 that I had just read from McKinsey, I believe, that stated that credit card debt is now higher than ever. Student loan debt is now higher than ever. And people cashing out their 401ks early is higher than ever. So I think while the stimulus did help during COVID times, the public health emergency has expired and we're starting to see the financial ripple effects of that. So it is something that you really need to keep in mind in terms of what is the best approach to collect from patients and how do you involve them in their financial conversations just as closely as you might involve them in their healthcare conversations. This chart is in here really to illustrate what that might mean to the average patient. So how underwater would they actually be depending on what kind of service was performed during their encounter? So how far does $400 actually take a patient? You can see for a standard physician office visit that they're pretty much at a break-even point. They should be pretty good, even under a high-deductible health plan. But any services performed beyond that, you really start to understand how underwater they are. So a CT scan, they're a little north of $400 underwater. An ER visit, I would say $297 is the low end. I would say they're probably more underwater than that. A vaginal delivery birth, over $2,700 underwater. An appendectomy, $3,500. These aren't small numbers. And a hip replacement inpatient stay, we're looking at over $7,000 underwater with no real idea or plan for how to go ahead and pay that. So why don't patients pay their bills? in addition to just overall ignorance, right? So, and that's not a knock on patients. The healthcare industry is extremely confusing. And as somebody who's worked in it for 10 years, I still find certain aspects of it confusing, and perhaps you do as well, with changing government regulations, changing economic landscapes that we're all dealing with, and most recently, surviving a pandemic. But why don't patients pay their bills outside of the fact that they just don't understand it? They don't know what an EOB is. They don't know how to reconcile it against their statement. What other reasons might they have for not paying their bills? Some folks just plain believe that healthcare is a right and they shouldn't have to pay their bill. I can tell you, having delivered multiple sessions of focus groups, I think I've spoken to north of maybe 10,000 patients in the last 10 years. They have no idea that not paying a medical bill could potentially negatively impact their credit report. They believe that those two spheres of their life exist completely separately from one another. Other folks were confused about what they owe, so they might get that initial statement in the mail or via electronic delivery, look at the amount that they owe, go, whoa, and choose to just wait. They just instantly assume that, oh, maybe insurance hasn't paid or it's not fully adjudicated, which we all know is not true. But for the patients, they don't understand that. So they might wait until they get that past due notice to actually choose to take action, at which case you're already losing revenue. There's already a decrease in time to cash. Other folks struggle because some hospitals have standard billing policies where about 2 weeks after a statement is put in the mail, that statement comes due, which is out of line with every other consumer relationship they have with somebody that they owe money to. Typically, it's a 30, 60, 90, in some cases, 120-day window that they have in order to meet their financial obligation. And then others of them just don't know there's any choice other than paying the bill in full. And that is so critical to communicate to patients, because if they don't know that, they don't necessarily have to work with, or they don't necessarily know how to work with you. They don't know how to reach out and start to have that dialogue and start to have that conversation. So in an ideal world, you want to have a payment portal or customer service folks that are willing to recognize a patient's financial situation with intelligence or automation and be able to speak intelligently to them and offer the right particular options for them. But they just can't pay it all at once. And what happens is they get frustrated and throw it away and just say, well, I guess I'll deal with the collectors when they call. And that's the last thing you want to happen. You don't want it to roll to that point where you have to potentially take extraordinary collections actions or send it to collections. And collecting patient payments does have a significant burden on the providers. You probably don't have staff that can make those outbound phone calls. And while you might deal with it systemically, for example, if you're an Epic institution, you might be triggering patient communications through MyChart, but it can cost up to 3 times higher to get a patient to pay than it would be to get a payer to pay. And on average, healthcare consumers pay twice as slow as a payer. So what can we do to solve that? Well, the first thing we can do is determine their ability to pay. And we'll talk to you a little bit more about how that works too. So it's important to understand self-pay behaviors. There are a lot of different vendor providers that offer a propensity-to-pay score. Some of them are demographic based, meaning that it's publicly available information that anybody can access to determine whether or not somebody is likely to pay their bill. And it might look at things like bankruptcies, divorces, liens, assets they pay taxes on, so assets under ownership, those sorts of things that are just publicly available, public record lookup. And then there are some that are credit-based that might actually look at a patient's debt-to-income ratio, not leaving any kind of a significant hit on their credit score. But if a patient looks, they may see a soft inquiry from a provider just if they're using one of those credit-based methods. So if you're considering using propensity-to-pay scoring, that is something that you want to go ahead and keep in mind. And in general, you've got high, medium, and low propensity. Different providers parse it out different ways. And then there's the willingness to pay. So they may have the ability to pay. You might have a high propensity patient, but they're just not going to pay you. Maybe they're not financially responsible. Maybe they disagree with the amount that you're charging them, and they're just not going to pay. Likewise, it's not weird to see a low propensity person making payments. And you're like, well, how does that happen? If they're low propensity, they probably can't pay. These are people who are culturally averse to taking charity or handouts. And these are also people who want to satisfy their financial obligations. They have it as part of their moral compass. And so it's important not to place undue financial burden on patients that you hope are going to be loyal patients to you and your facility over time. That's why it's important to really have a feel for where is somebody in terms of their ability and willingness to pay at this particular junction when you're getting ready to at post-discharge or even pre-service if you're asking for payment. I get it. Culturally, it's very uncomfortable to have those conversations in a healthcare setting. Traditionally, for years and years and decades, we didn't have those conversations with patients because we were getting the majority of our revenue from payers or the government. But times have changed. And how do you best equip your staff to have those uncomfortable conversations? And how do you do it with grace? So we'll talk a little bit more about that in just a moment. The collection rates that we get from patients do lag their ability and willingness to pay. So I do believe it is foundationally critical for you to have some solution in place that will give you a read of a patient's financial situation. Now, here at FinThrive, we do offer propensity to pay scoring, and we also offer financial assistance screening as well to see if somebody might pre-qualify for financial aid based on your hospital's financial assistance policy. But you want to be informed when you're having that conversation. In in the majority of other consumer relationships, a car loan, a mortgage, an application for an apartment, an application to turn on utilities, your phone bill, toll tag, they're running a credit report to see if you're worthy. Not worthy. Worthy's not quite the right word. If you're able to meet your financial obligations as a customer of that particular product or service, hospitals really need to get there as well. And there is a direct relationship between the amount they owe and their propensity to pay. So if you think back to a couple of charts ago where we're seeing those high deductible health plans increase, and we know that the majority of patients and consumers in the United States don't have more than $400 in savings, how do we deal with this reality? Providers are calculating a propensity to pay score, whether the patient is insured or not. And the presence of insurance doesn't always necessarily translate to the ability to pay. It does help, obviously. But there are also hospitals that have programs in place where they might automatically discount somebody who does not present with insurance. So you might only owe 70% of your outstanding balance because somebody at the hospital has calculated that that's what an uninsured patient is likely to be able to pay. It's very important to focus on high pre-service patient balances before they come in for the next service, or true self-pay patients to see if there's something that you can do there. So it's important to look at, again, you're looking for a score provider, whether it's FinThrive or somebody else that can help give you that insight into their propensity to pay, how they might be able to best meet their financial obligations, and determine whether or not maybe the visit should be free based on their indigent status, or whether or not they meet the requirements of your financial assistance policy. Typically, hospitals that do apply presumptive charity scoring to either back-end statement processing, pre-service, it's not done so much. Could it be done pre-service? It might, if you're a more advanced hospital in terms of your ability to do more and collect more upfront. There's no reason not to have the conversations at that point in time. But for some hospitals, that translates to 25 to 30% of self-pay accounts that would have otherwise gone to bad debt. So that's one way, one quick and easy way that you can reduce bad debt by converting those accounts to charity based on your financial assistance policy and suppressing the bill. Maybe that patient just never gets a bill. You don't necessarily have to draw their attention to it. You don't have to send them a letter that says, based on your estimated income, because then you might run into those low propensity patients that are proud and don't want their balance waived. So I would say from a best practice perspective, there's no need to call the patient's attention to it. I would just suppress the bill on the back end and then take that encounter and convert it over to community benefit under 501R. And that's one way that you can protect your revenue, although in that situation, you're not collecting, you're just taking the money that would have gone to bad debt and you're classifying it in a different way. So let's shift the focus to how do we get more revenue and how do we protect the revenue that we've got? So what we want to do is search for different things that we have in our arsenal to help patients pay their bills or help us protect our revenue as providers. So the first thing that we recommend is identity verification. Are there any red flag or medical fraud behaviors with this patient in the past that you might need to be on the lookout for? Is their mailing address that they provided in their registration or check-in actually accurate so that you know how to contact the patient about a financial obligation post-discharge? Insurance discovery and presumptive charity are also extremely important components as well. Insurance discovery, which is the business that I run here at FinThrive, we can go and look for coverage for true self-pay patients who don't present with any policies at time of service, or we can even look for secondary coverage. So maybe there's Medicare with a commercial as secondary or the opposite way. We can locate all of those things for you. And then, of course, you want to run propensity to pay too. And you don't have to just do it on high balance accounts. If you'll recall from earlier in this particular session, sometimes a bill as high as $150 is enough for somebody to need financial assistance. So it is very important that you continue to check into that. Now, 1% to 5% of self-pay accounts we have found through proprietary research that we've done here that are written off to bad debt actually do have valid and active insurance coverage. So if you're using a service like FinThrive's Insurance Discover service, one of the things that we can do is, again, mitigate bad debt by finding that insurance coverage, helping you to resubmit it and rebill it, and then make sure that when the patient does receive their final bill, it's as low as possible. And that is one of the key drivers to reducing call center volumes, increasing patient satisfaction, and reducing AR days. And 30% of those self-pay accounts will generate 80% of the cash that you collect. So it's really important to have a discovery solution in place for both the patient and the payer. And you should really screen 100% of patients. Even if they do present with coverage, you might get into a coordination of benefits situation where you're not sure which coverage is primary versus secondary, or even if there is a secondary coverage out there. Some patients even have tertiary coverage. So anything that you can do to, again, mitigate any financial risk that you have as part of revenue management, you want to go ahead and do that. Also, I'm going to say it again, screen for financial assistance. If that bill should be waived because they qualify for financial assistance, go ahead and do that so you can show community benefit. And again, leverage propensity to pay. It's not that expensive. It's typically less than the cost of postage. It's something that makes a significant difference in your overall profitability. I've got a sample workflow on the screen. I'll talk to it at a very high level. So let's say this is sort of a post-discharge after service scenario. So did we find coverage? Yes or no? If we did find coverage, did we already collect the patient payment? If not, we might want to run financial assistance screening or propensity to pay scores so that we know exactly how to adjudicate that account prior to sending out the patient statement to try to collect that payment up front. And you can cascade it. This is just one example of maybe how you could approach that. There are lots of different ways that you can do it. And most best practice partners like FinThrive or any other vendor out there can help work with you to configure it. We've got a best practice scenario here, but it might not quite be right for your situation. And that's why you want to have informed experts available to help you. And you want to capitalize as much as possible before discharge. So anytime you can look for insurance coverage or run financial assistance screening or run propensity to pay, there's lots of places that you can do that. Scheduling, pre-registration, registration, pre-discharge and checkout, as well as prepayment. So there's lots of opportunities. So it's important to have different checklists and gates when it comes to the patient intake process. So from an eligibility perspective, we want to understand if they have coverage or if they're true self-pay. We might do that with a 270, 271 exchange through your EMR, or you could do it through a third party like FinThrive. From a benefits perspective, once that coverage information comes back, we might want to check to see if the particular service being performed requires authorization, a referral, or any other notification to the payer prior to them approving that the claim can be processed. Is it medically necessary, for example? From an estimation perspective, does the patient have any idea what they're going to owe? With the No Surprises Act and the Price Transparency Act, it's really important to make sure that you're being as patient-friendly as possible. And then when it comes to collection, are you running coverage discovery? Are you looking for revenue assurance like propensity to pay and financial assistance screening? And is your patient payment process optimized to leverage that kind of insight behind the scenes? Do you have scripting for your customer service representatives or your registrars? I've got a sample financial clearance workflow right here. I'm not going to talk to it too much. I apologize that the font is small, but really you just want to, this is more of a workflow diagram that outlines the 4-step process that I outlined previously when it comes to eligibility, medical necessity, any sort of pre-auth, the benefits basically of the coverage that we find, how to have that financial conversation and let the patient know with an estimation solution how much they might owe. And then finally, making sure that your patient payment processes are as optimized as possible so that as you ask for money, no matter where in the revenue cycle we happen to be, it's done with sensitivity and grace. And there are a lot of innovations in the space. So let's just touch on a few of them. So let's talk about revenue cycle transformation and a consumer's market, because the patient technically is your consumer. The patient is your customer. And if they have a bad financial experience, that tends to correlate directly to them ever returning to your facility again. Even if they had the most amazing course of care, even if you were able to perform a life-saving procedure, if afterwards the billing experience is horrible, they're likely to spread negative word of mouth and they're likely never to come again. And when we're competing with disruptors like Amazon, who's gotten into the healthcare game, or CVS, who's gotten into the healthcare game, they know the consumer. They know how to speak to them. They know how to foster those relationships. We don't want our hospital providers or our traditional physician groups to be at a disadvantage. So they are typically shopping around. Most statements, they have about 4 months to pay. There is a risk because most of the billing is done downstream, post-discharge. A lot of things are still mail dependent, and there's pros and cons to that. I know a lot of providers have gone digital, and there's nothing wrong with that as long as you let the patients know upfront that that's what you're doing, and I'll make it very easy for them to opt out because, hey, like me, some folks are old. Some folks like print. They want to be able to look at their EOB, which might be delivered via print, and compare it against their statement, which might be printed. Of course, they can do it electronically and print it themselves, but I am saying snail mail is a little bit less of a consideration now than it used to be. And then how much can they afford? Do we have those conversations? Do we let them know that payment plans are available? And if you're a provider that does offer payment plans, what are your policies? How long do they go out? Is it a year? Is it 2 years? How are you calculating the amount that would be the best amount for them to pay? I think there's a lot of intelligence that needs to happen there as opposed to, I've seen a lot of what I call basic yardsticks. So let's say if the patient balance is under $500, the most that they can extend it out is 3 months. So let take the 500 divided by 3. That might not work for some folks. So again, you want to use that intelligence that you get from the propensity to pay scoring all the way throughout your entire financial process. You might need to update the way that you do payment plans based on the financial tolerance of your patient population. So that's your traditional, as we've been talking about in this particular session. Let's be innovative. Let's embrace that disruption. Let's run patient financial clearance upfront, pre-service. Let's leverage propensity to pay, whether it's credit data or demographic data. There's so many options available. You really ought to be doing it. Let's set up some pre-established payment plans that are patient-friendly in terms of their guidelines, and let's collect that first payment. Let's generate more interest-free loans. Does it have a little bit of a negative impact on your overall AR? A little bit, but it's better than getting zero. It's better to collect as much as possible over time as opposed to zero, which is what patients tend to default to because they're very frustrated by the healthcare space. Any collections that you can do at point of service are critical. If you are not in a single business office situation yet, maybe you have a healthcare group and a physician group, if you can consolidate those bills, it will significantly reduce patient confusion. because they'll feel like, oh, I just paid this bill for this visit, and now I'm getting another bill for this visit. And they might rip it up and go, it's wrong. But one might be for the anesthesiologist and the other one might be for the physician. So it just depends, right? As much as possible, if you can consolidate those billing statements, that's really the optimal patient experience. And that's really a transformation of looking at it from a guarantor level or an MRN level as opposed to an account or an encounter level. And then any segmentation that you can do with bad debt, there might be, outside of sending it to a collection agency, there might be other options available. Or can we put automation in place, for example, to do financial screening to see if somebody pre-qualifies for charity or free care before it goes to a collections agency. So there's lots of little things that you can do. You definitely want, as much as possible, to have a unified self-pay collections process. It increases reimbursements, it improves cash flow, it reduces your overall vendor contingency and puts more power back in the hands of you and your staff. And if you're a not-for-profit institution, it assists with 501(r) reporting. And what all of these things that I've discussed with you today lead to is an optimized and efficient revenue assurance model. That is what you want. It doesn't sound that innovative, but I have found in the 10 years that I've been in this space that it actually very much is. If you can locate unknown coverage or potential underpayments, if you can report on coverage and claims that drive incremental revenue, and if you've got a solution like mine in place that is a safety net for revenue leakage, that's absolutely critical. I can say we find on average millions and millions of dollars on behalf of our clients in terms of active coverage that was not presented at time of service or even post-discharge. And all of these things really add up. It allows you to closely monitor the relationships between your institution, payers, and patients. It helps ensure efficient and timely reporting on any payable coverage and claims. You can leverage multiple delivery mechanisms, no matter if you're doing them through your EMR or if you're supplementing with an outside vendor. It helps really highlight demographic discrepancies between provider and payer. And it helps you really understand the community that you serve a little bit better. And all throughout, under this entire umbrella, you're focusing on a holistic approach that identifies all potential sources of revenue in this equation, and you're doing it in a sensitive way that benefits patients. So in closing, in my experience, some attributes of successful organizations that are doing it right look like, hey, they don't worry about it. They don't need to have a big decision by committee. They make a decision to try it, and they just do it. And it's typically an iterative approach. We might start with just implementing propensity-to-pay screening, or we might start by just implementing an insurance discovery solution. It's important that these things are small, that you can build on, that you can measure, that you can demonstrate success, because once you start to get the momentum, any roadblocks that are typically encountered, maybe it's cultural aversion or market change, maybe you've got a suddenly a consolidated competitor that, is now playing in your space because of hospital consolidation. It's important to be proactive and thorough. So that's, again, two adjectives that I would use to describe best practice providers. Talk to patients early and often. Don't be ashamed to have those conversations. I'm sure you're delivering amazing healthcare. There's no reason to be embarrassed about asking for money. If you know the patients are going to get what they pay for, which is excellent service, excellent care, you don't have to be embarrassed to have those conversations. Trust your staff with those difficult conversations. Obviously, set them up for success, but don't be afraid to trust them to have them, and trust your patients. Most patients, in my experience from all the focus groups that I've done in my life, they want to meet their financial obligation. They want to pay their bill. They're good people that want to do the right thing. And organizationally, this creates a transparent revenue cycle where people can see all the levers that drive revenue and understand, oh, that might be a problem area that I was previously unaware of. What can I do to close that gap? You're leveraging technology to empower staff as opposed to putting additional manual processes on them. Nobody wants that. You don't want that. They don't want that. It slows time to cash. It lowers staff satisfaction. It can increase resource constraints. Be like the Maries, adapt, improvise, overcome what you happen to get to. just keep rolling, keep focusing on what you need to focus on, which is, again, eliminating as much revenue leakage as possible and improving the patient satisfaction as much as possible, and be as frictionless as possible. Frictionless is one of my favorite words because I think the patient payment experience is fraught with friction. So anything that we can do to make it easier, smoother, more intuitive, if we disclose all of the different ways that a patient can satisfy their financial obligations early and often, that makes a huge difference because it creates patient loyalty. So thank you so much for your time with me today. I hope you found the session informative. If you would like to speak further with me about any of the topics that we covered today, as you can tell, I love this stuff. I get so fired up when I have the opportunity to discuss it. And I love supporting the healthcare community. I love you guys and I love what you do. So anyway, I'm here if you need me. And otherwise, I hope you have a wonderful day. Thank you so much for your time.